IO-access has been used since World War II, and there have been many devices over the years, most of which were manual devices, and those devices still exist. There are devices meant for both adult and pediatric use in the sternum, in the proximal humerus, and in the proximal and distal tibia. One of the limitations in adult situations, however, particularly in the tibia, is that the bone is thicker and harder to get through in a manual fashion. So over the years, there have been other devices on the market that have been developed, one of which is a power-driven device. And this is one that is used in adults and pediatrics, both in the proximal humerus as well as the proximal and distal tibia. In pediatrics, this power-driven device can also be used in the distal femur. There are a lot of different nuances to the different devices that are out there. Other devices are spring-loaded, and there are spring-loaded devices for both adult and pediatric, and those are indicated for sternal, proximal humeral, and tibial sites. You do need to be cautious of the indications and contraindications as well as approved sites of insertion for all the devices on the market, because they do vary from one device to another. So one of the things I hear a lot from people that are advocates of IO-access is that they only use it in dead adults and sick babies. And so one thing to consider is that there are a lot of clinical conditions where one should consider IO-access besides just cardiac arrest and respiratory arrest and very sick near-death children. There are a lot of clinical situations that are time-sensitive where there is the need for rapid delivery of either fluids or medications or antibiotics. Many of those are shown on this slide, and I won't get into the details of them, but it's very intuitive that in sepsis and in cardiac dysrhythmias and in status epilepticus and traumas and other situations, vascular access can be difficult. In some of these situations, patients are in shock or they're dehydrated, and vascular access in a peripheral IV can be very difficult and challenging. So more and more IO-access is being turned to as a bridge in these situations until one can get definitive peripheral and or central vascular access. A common argument I often hear from people who are using IO-access but who tend to use the tibia is that there's too much going on at the head of the bed. So there's a reluctance to go up there to place the IO. This photo is supposed to show this pit crew approach, which basically shows that there really doesn't need to be that much going on at the head of the bed. There's usually one person managing the airway. There's one person on the side of the bed doing chest compressions, and the person on the other side of the bed typically is looking for an IV, but one can argue that it might be faster to just go up to the head and landmark and insert a proximal humeral IO. So this is an argument we hear, but I do feel that it's not with much merit. So I've touched on indications for putting an IO in, but I think it's important to remember and review some of the contraindications to placing an IO device, regardless of which device you're using. Most of them are intuitive, but it's good to review these. One of them is a fracture of the target bone. So anytime you're placing an IO and there's a fracture anywhere along that bone, it's contraindicated because there will be extravasation of the fluid infused out of where the fracture fragment is. Infection at the area of insertion. So if there's a patient that has cellulitis, obviously you're not going to put an IV or an IO through that area of infection. Inability to identify landmarks. So if you have someone who has, either due to obesity or muscularity, a difficult time palpating landmarks confidently, then that's a contraindication to using that site, and one should search for a different site. IO-access or attempted IO-access within the target bone within the previous 48 hours. So if an IO was either dislodged or an attempt was made to insert an IO and it was unsuccessful, one needs to wait at least 48 hours before reattempting an IO in that same bone. Prosthesis or major orthopedic surgery near the insertion site. So if there's a scar over the joint and it's possible that there's hardware at that site, then one does not want to place an IO in that site. So I've talked about the benefit of the proximal humerus with regard to discomfort and how it's much less discomfort than when given in the tibia. There are a lot of other advantages which have even more of a clinical importance, and one of those is the flow and how quickly fluids and medications can enter the central circulation. So in studies that have been done, it was found that it's approximately 3 seconds to get to the heart when fluids and medications are administered into the proximal humerus. And flow rates have been found to be on average about 6.3 liters per hour, and that's when you're using a pressure bag or an IV pump. We've mentioned already the lower amount of discomfort from insertion and infusion, and in the study that was done that I alluded to earlier, they did find that less medication was required for management of pain when subjects had the IO placed in their humerus versus their tibia. So this slide reviews the anatomy and physiology a little bit. One misconception people have is that medications and fluids take a long time to reach the central circulation. On the contrary, the medullary space is highly vascular, and this slide shows the anatomy and the highly vascular area in which we're placing these IO needles. There are a lot of these bridging veins and Haversian canals that transmit fluids and medications from the medullary space to the venous circulation. And unlike veins, central or peripheral, which typically will collapse when someone is in hypovolemic shock, for instance, one can think of an IO access site as being a non-collapsible vein. However, one thing to remember, as you can see in the picture in the upper right-hand corner, is that spongy bone, so to speak, is filled with fibrin and marrow, and one of the things that is required for one to get the flow rates I've talked about is a rapid flush of saline to displace some of this marrow and fibrin that's present in the medullary space. This slide shows the anatomy, and we'll tee up the next slide, which is going to show you a live fluoroscopy where contrast was administered in the humerus. And you can see a lot of the bridging veins that empty the medullary space of the proximal humerus and empty into the axillary vein, which changes nomenclature once it crosses the first rib and goes under the clavicle. That vessel becomes named the subclavian vein. So when physicians are placing central lines, we're cannulating the axillary vein and or the subclavian vein. Everything that goes in the humerus goes almost directly into that central circulation. The picture at the top is a cross-section of the shoulder to show that there really isn't any major structure to worry about also when you're inserting an IO. So there's deltoid muscle and skin and adipose, but the axillary nerve, artery and vein, brachial plexus, all of that is more medial in the axilla. And where we're placing the IO on the anterolateral part of the arm is far away from any of these important structures. In the diagram, you'll see the greater tubercle pointed out, and that's the target of insertion. The biceps tendon is what sits just medial to the greater tubercle, and that's really the only structure that needs to be avoided. And in landmarking techniques that are being taught, there are ways of positioning the arm such that that tendon will be out of the way and displaced more medially so it won't be injured in the process. This video was a real-time fluoroscopy done actually on me. I volunteered for this. 10 mLs of iodinated contrast was injected into the humerus, and you can see the yellow and the blue, which was colored to help outline where the IO needle is and the outline of the humerus. As you can see, contrast leaves the humerus and enters the axillary and then subclavian vein very quickly and reaches the right atrium in under 3 seconds. So this demonstrates quite well that you get flow rates and rapid delivery of fluid medications, much like you would through a central line, but not nearly as timely or time-consuming of a procedure as a central line would take. Landmarking of the proximal humerus is quite simple. The first thing to do, as I mentioned previously, is to help rotate the upper arm internally so as to displace that biceps tendon. And this can be done one of two ways. One is to place the hand over the abdomen with the arm or elbow tight against the body. The other is to place the arm at the patient's side, rotate the hand, and internally rotate the arm so that the palm is facing outward and the thumb is pointing down. both of these maneuvers will achieve the same result, and that's internal rotation of the humerus. The next thing you'll want to do is to place the palm of your hand on the shoulder anteriorly, and you'll feel kind of like a ball-like structure under the palm, which is kind of the general target area of where you're going to be inserting the IO. What's important to remember is that the humerus, at least the target of insertion in the proximal humerus, is on the anterolateral part of the humerus, and the humerus does lie much more anterior to the midline than people realize. So when you feel this ball, you need to push somewhat firmly. Even on obese patients, you should be able to feel this fairly easily. Now, muscular patients, it may be a little more challenging, but this is just going to give you a rough idea where the IO is going to be placed. The next step will take two hands, and you'll place the ulnar aspect of one hand vertically over the axilla. You'll place the ulnar aspect of the other hand along the midline of the upper arm laterally. And then you'll drop both of your thumbs down together over the arm, and you'll firmly push with your thumbs and slide up and down the arm until you feel the surgical neck. Now, the first thing you're doing when you're dropping your thumbs down is you're identifying the vertical line of insertion. So it's the anterolateral part of the arm. So the IO needs to be placed somewhere along that line where your thumbs come together. And that keeps you from putting it in too anteriorly or too far laterally. As I mentioned, you want to palpate up and down, and I usually do this with both thumbs. In this picture, they're showing just one thumb, but you can use your thumbs to palpate and slide up and down until you feel a step-off or a ridge. And that's where the shaft of the humerus meets the round portion of the humerus. And this is where the surgical neck is. That area will feel somewhat like, if you can picture a golf ball sitting on a tee, where the golf ball meets the tee would be the surgical neck. One of the important things I like to tell people when they're feeling for that surgical neck, though, is not to march up the arm with their thumbs, because sometimes they'll skip over that site. It's important to keep firm pressure on your thumbs and slide up and down the arm until you feel that ridge. It'll feel like a speed bump, so to speak. So it's very important to try to do it that way. Once you feel that surgical neck, the insertion site will be 1 or 2 centimeters above that on the most prominent aspect of the proximal humerus, which is the greater tubercle or greater tuberosity. So I've shown you how to landmark and how far up and down the arm to place the IO. Again, to review, it's 1 or 2 centimeters above the surgical neck. The next most important part of the insertion is to make sure that the angle of insertion is correct. What you want to do is point the needle tip at somewhat of a 45-degree angle to the anterior plane. And what that means is, rather than the lateral part of the arm, which is where most, for instance, in the hospital, nurses place IM injections in the deltoid muscle laterally. You don't want to be laterally, and you don't want to be too far anterior either, or you'll hit that biceps tendon that we talked about. So the needle tip needs to penetrate through the skin approximately 45 degrees anterior to that horizontal plane. And you want to point the needle, in other words, the trajectory of the needle should be roughly 45 degrees downward. The reason it's important to point the needle caudal or downward rather than laterally across the patient's chest or toward their head is, as you can see from that diagram in the lower right-hand corner, when the needle is placed laterally, you'll traverse what's called the epiphyseal growth plate. And in adults, this is a very dense calcified shelf of bone that separates the proximal humerus almost into 2 compartments, the upper of which is that round, smooth, dome-shaped portion of the proximal humerus. That portion is actually what's called the humeral head. A lot of times people call this a humeral head IO, and that's somewhat of a misnomer. It's a proximal humeral IO. The humeral head is what you'll see in the picture on the left, where the tip of the needle is, and it's above the epiphyseal growth plate, and it's been found that there's very little vasculature there, so you won't get the IO to flush nor infuse very well when the tip is sitting in that location. So you want to actually direct the needle downward. I found that once I landmark the patient, or you could even landmark from the head of the bed, if I'm landmarking from the side of the bed, I step up to the head of the bed, and that helps foster that angle downward. It also gets me out of the way in case someone needs to come to the side of the patient and take over chest compressions. So that downward angle is shown in that picture on the lower right-hand corner, and that avoids that epiphyseal growth plate and gets the tip of the needle where the highest flow is found. Just to review, we talked about the fibrin and marrow present in the medullary space, so it's important to do a rapid saline flush after the IO is inserted. In adults, it typically takes 5 to 10 mLs of saline flushed rapidly, and that's the part that might cause some discomfort in an awake patient, but as I mentioned, that can be mitigated by lidocaine. In children, however, less saline is required to flush, and it's recommended that we use 2 to 5 mLs of saline. And I perhaps wouldn't flush as vigorously in a pediatric patient because infants and small children's bones are softer, and too much pressure generated may cause the IO needle to dislodge. There is an inherent pressure in the venous circulation that one needs to overcome, as well as resistance in the bone marrow space. So for the optimal flow rates that we discussed, which is typically about 6.3 liters per hour in the humerus, you need to use a pressure bag or an IV pump of some type of pressure. Flow under gravity won't be as high, especially in the tibia, when one hangs a bag of IV fluids to gravity. So you need to use a pressure bag. Also, what's commonly asked about is what medications can you give, or what dose can you give, what rate can you give them. Basically, whatever dose, rate, or concentration you would give a medication through a peripheral IV, it would be the same for the IO. There are recommendations available that are meant to help alleviate the discomfort of IO, as I mentioned previously. This chart will show you the recommended protocol to use with lidocaine. It's important to remember that this is not the same lidocaine that we use for local infiltration when we're doing a procedure. It's the lidocaine that we used to call cardiac lidocaine, so it's 2% preservative-free, epinephrine-free lidocaine. In adults, the initial dose should be 40 milligrams, which is 2 mLs. What we'll typically do is prime the extension set with lidocaine, and that holds 1 ml, so half of the dose will be in the tubing. And you'll slowly infuse this over 1 minute. You'll switch to a saline syringe and administer the second ml of lidocaine, which is still in the extension tubing. And that way you've given 2 mLs of lidocaine over 2 minutes. It's recommended that you allow that to dwell for approximately 60 seconds. I like to say let it marinate. And then you go ahead and administer the 5 to 10 ml saline flush. After the flush, an optional 20 milligrams of lidocaine might be administered as well. Altogether, it may take about 4 minutes or more to administer lidocaine slowly in this situation. So obviously this is something that you're going to do only in patients that are awake but stable. If patients are unconscious or nearly unconscious or unstable, you don't necessarily need to follow this 4-minute regimen. In pediatric patients, the same protocol should be followed, only the dosage is 0.5 milligrams per kilogram up to a maximum dose of 40 milligrams for the initial dose. We discussed the history of IO access, and there are a lot of devices on the market, both manual, power-driven, and spring-loaded. We also discussed the benefits of the proximal humerus. So if you're using IO access right now with one of the other devices, that's fine. I just encourage you to consider using the proximal humerus because it does have distinct advantages for the patient clinically. If you're not using an IO access device yet, you should strongly consider one of the powered devices, which is the EasyIO, brought to you by Teleflex, which is the sponsor of this webinar. What I do like about the EasyIO system is that it does give you the power and control of the insertion, which is important in pediatric patients because you need to have that tactile feedback. So one caution with manual devices or others on the market might be not being able to feel that tactile feedback and controlling where that needle stops. So although IO access is typically quick, regardless of which method you're using, it's important for it to be safe. And the EasyIO is a safe device. There have been very few complications using this device. It's very fast, it's effective, very versatile, and very convenient. So it does have a lot of distinct advantages for the clinician. It's been widely accepted in both the pre-hospital and hospital setting. Again, I do think that regardless of your device you currently may have, my feeling is that the proximal humerus site, at least in older adults or older children and adults, needs to be utilized more often. And also, you need to consider using IO access in situations beyond cardiac arrest. So there are a lot of emergent, urgent, and other medically necessary situations that require timely access and timely administrations of medications. So consider using this in your sepsis populations, in your trauma patients, status epilepticus. There are a lot of situations where we're trying over and over to get IV access in difficult vascular access patients. There are a lot of delays to vascular access that can negatively impact patient care. And one of those is sepsis. So delaying antibiotics in the setting of sepsis, delaying blood product delivery in a trauma patient, these all have negative impacts on patient outcomes. Not to mention the damage we're causing to patients' vasculature with peripheral IV attempts over and over. And this is especially important in the renal population. As our baby boomers are aging, we're getting a higher and higher percentage of patients that are going to be dependent on dialysis someday. So vein preservation is something that we forget about in the pre-hospital and even in the emergency department setting. We're sticking people in the arm over and over and over again, and these patients may need those veins later on in life for creation of an AV fistula to facilitate hemodialysis. So we don't think about the consequences later, not just the delay in giving therapy, but the consequences of multiple unsuccessful IV attempts in these patients. So consider using IO access in expanded situations. Definitely use the proximal humerus when you're able to feel landmarks appropriately, and consider using the EZ-IO because it's just a really easy and safe, effective device. Thank you for attending the webinar, and I hope you learned a lot from this presentation.